It's truly a pleasure to have the opportunity to look into that crystal ball for you. By the way, I do have a crystal ball on my desk in my home office, and I would love to be able to bring it to engagements, but I don't know how TSA would deal with it. So that would be a challenge. But we all have our own challenge for the healthcare delivery system's future. And so I'm going to not make a prediction about it, but forecast the future of healthcare and help you explore the realm of possibilities, which I believe can only be actualized to their full potential with the full involvement of the business community. So although most of my presentations are to groups of hospital leaders or medical groups, pharmaceutical industry representatives, I really think the secret sauce is the business community. And I'm not pandering to you. You can read any number of those books and the like. So I'm going to take you on sort of a whirlwind tour of what I see in this fuzzy picture of the future of healthcare, and end with some challenges for the role that the business community, in my opinion, has to play. Now, because I speak mostly to medical and hospital groups that have all sorts of requirements for continuing education, I start with disclaimers, and I'm totally independent. I don't work for anybody else. Virginia Chamber hasn't vetted my comments, and I'm really on my own. I must usually disclose whether I have any investments or employment relationships that would color my interpretation. The answer is no. I refuse to invest in healthcare and don't have any checks coming from anyone else. And so you're going to hear my own independent thoughts. You're also going to hear me be very critical of the current approach to health reform, the Affordable Care Act, but you must not, in the same token, believe that I'm a shill for what the Republicans would do. Because although the political cartoons quite appropriately slam Obamacare for the Rube Goldberg that it is when they turn to the Republicans and say, well, got any alternatives, Mr. Einstein? Sadly, I think as I try to parse what the Republicans are doing, they're still LFI care. I don't for a moment look to the district just to the north of your great Commonwealth and expect any solutions out of there. Again, reinforcing my belief that this is the exact audience that really needs to get totally committed to building the great healthcare system that we can do in this country. Now, I'm a big believer in American exceptionalism, and there's no reason in the world why we shouldn't have the world's best healthcare delivery, but we don't. You can look at any number of international data comparisons. The two biggest ones are the Organization of Economic Cooperation and Development and the World Health Organization. OECD looks at healthcare and ranks all the countries on the basis of really sort of bang for the buck, based on percentage of gross domestic product spent on healthcare, how healthy are the people. We come in 34th, interestingly enough, on a list of 34. So we don't do well in a return on investment. For the World Health Organization, which just looks at overall health, we come in 39th out of about 200, might sound better, but again, almost every country in front is one that we think we could and should do better than. But even though as a country we do terribly, we have pockets of world-class excellence. There's no question, and I validate this as I travel around the world and give a couple of speeches a year in other countries, that the Mayos, Cleveland Clinics, Kaisers, Geisingers, and I could add a long list, and it would include some great Virginia institutions, that on a selective basis are the places where the rest of the world comes for its health care. So they would never come to the United States and be randomly assigned to a health system. That bothers them because we don't do well overall, but we're perfectly capable of excellence. And one of the points I want to stress is really the core almost of my disagreement with the Affordable Care Act is it wants a one-size-fits-all solution. We've got all these experiments and demonstration programs, many of which are probably affecting the providers in the audience, to try and find out what's going to work. And yet, if you look at the Mayos and the Clevelands and the Kaisers and the Geisingers and the Intermountain Healthcares and the Virginia Masons and compare, they're all different. They're all excellent in very different ways. And they are also constantly changing. So again, part of the flaw in the Affordable Care Act is this desire to spend a couple years and tens of billions of dollars trying to find out what's the right model for the United States. And the models they're studying, which are these organizations, are constantly changing, and again, changing in different ways. So hats off to diversity, hats off to the vitality of the business community that can imagine things being different. And what a great environment in which to be exploring those differences, because I'll put my reputation on it, and I'm not pandering to you today. I've got too much of a paper trail to walk away from this. I have been in healthcare almost 50 years. Graduated from college a little over 46 years ago and been in the healthcare sector full-time ever since. So I've seen almost all of the last 50 years in healthcare. And we've seen changes every decade. You can sort of identify this segment of the healthcare delivery system became differently. But we're at the stage right now in 2015, between now and the end of this decade, when it's tighten up your seatbelts, hold on, because we're going to see dramatic change like we've never seen before. And I will elaborate that, but anytime I use or see the word change, I immediately think of strategy. Having a PhD in economics, and I ended up studying how doctors cost their services. Ended up my thesis advisor right out of the business school, so he got me focused on Peter Drucker and strategy. And I was in graduate school right after Drucker wrote that 700-page book that a few of you in the audience have probably read. But strategy, this idea of purposeful response to anticipated change consistent with mission and values. I'm not here to talk about your mission and values. We've got some great panelists and speakers who are going to follow me with some super missions and values that they're actualizing. But I'm here to talk about the change and to help orient you to some of the choices that you'll make. Again, that sense of the realm of opportunities that was built into the title of my presentation. Now, strategy and tactics are not the same thing. You as business leaders, and I know the healthcare executives in the audience deal with this difference all the time. That's the difference between the CEO, who's responsible for looking at what changes do we have to make so we'll be in the right place in the future, versus the COO, who has to, on a daily basis, see all the factors as fixed, meet the goals, make the numbers, make the best decisions based on what supplies are in the closet and what employees showed up and what patients are in the beds or in the outpatient clinics, and do things right on a day-by-day basis. That's tactics, and hats off to tacticians. I discovered when I ran my own company for a while that I'm a terrible tactician, but I really, therefore, respect all the more the people that do that. But my excitement comes, and the reason it's such a pleasure to be able to address you today, is in this idea of seeing everything as variable. The service line that maybe it's your reputation, what made you strong for the last 100 years, but maybe it's not the future of American medicine. It's the kinds of relationships you had with your medical staff or with other types of providers. I'm assuming, and have structured my presentation to you today on the assumption that all variables or all factors of production are variable, and that includes those that could be addressed jointly by the business community and the provider community. I also think we need to identify the possibilities, hence the focus of the rest of my presentation, the way I've organized it, but make tough choices, discontinue some things, go into different lines, develop partnerships with people that in the past we thought were the scum of the earth, the competitor down the street we didn't want anything to do with. We have to rethink everything, and it's my firm conviction, looking at many examples, not only around the country, but here in the Commonwealth of Virginia, that we see this works, but we've got to do the right things. And by the way, I see a few of you taking notes. Don't worry, the Virginia Chamber will make my slide deck available to you right after the conference. So I'm sorry, I should have started with the comment that not only will I be here all day to engage you in discussion, as Barry mentioned, but I will make sure my slides are available. So don't worry about taking rampant notes. But here I'm talking about making these big decisions, reallocating resources, redeveloping partnerships for the good of the common good. Well, how can you as Virginia's business leaders do this in an environment of unprecedented change when the medical marketplace, as I've already argued, over the next 5 years is going to be more different than it was over the last 45? That may sound like a pretty daunting challenge, and it's why I love looking in the crystal ball and sharing my perspectives with people. Well, how do you do that? You can implement the Affordable Care Act, but you'll see where I think that leads in a moment. You can read Modern Healthcare and the other trade journals, Wall Street Journal, New York Times, lots of coverage of this industry of ours. You can go to meetings and see what others are doing and share notes and find out what else you might do. Or you could bring in a futurist too, as Barry suggested, predict, to look at the trends and the like, or to forecast based on possibilities. Now, do I have any former students in the audience? I spent almost 20 years as a professor at 2 medical schools, and so in a given, especially in a clinical audience, I'd have a former student or two. Anybody that ever took a class from me knows that if you see 2 words in red on a slide that Bauer prepared, it's on the exam. Okay, so this is important for those of you taking this seminar for credit. But you're immediately thinking, well, predicting and forecasting are synonymous. No, they are not. And I've actually been an expert witness and won a few cases on that distinction. But let me make the point for you. Predicting is a science. It's highly mathematical and well structured and really doesn't vary in practice. But a prediction, specifically defined, is an estimate of the value of a key variable at a future point in time. So what you do is you find something you're interested in. Where's it going? Healthcare as a percent of Virginia's gross domestic product, or the number of doctors we'll need to supply healthcare if the Affordable Care Act were to succeed. You look for something and say, what's the number we can expect 5 years from now? And then often you try to make your corporate decisions mesh to be at that point in the future. But you've all done this. You specify the independent explanatory variable you're looking at. Then you try to figure out how medical science and technology and the economics and the political environment, insurance, et cetera, change. You look at these large historic databases, and we're rampant with them. And then you bring in some smart whiz kid, a quant, if you will, to find the mathematical equation that best explains how that relationship evolved in the past. And then you simply extend the line out into the future. Well, I'll use government data to show you exactly how the Obama administration did that. The day it went into the White House in January of 2009, it brought Peter Orszag over from the House to where he was the Congressional Budget Office Director to the White House, and asked Orszag to look at healthcare as a percent of gross domestic product, because as President Obama said in a speech he gave just about a week ago, as he began his administration, he was really concerned about healthcare as a foundation not just of a state's strength, but of the nation's strength as well. So we had Orszag, who has exactly the same degree I have and could teach the same classes that I've taught in how to do predictive science, predict the healthcare as a percent of gross domestic product in 2015. So in January 2009, Peter Orszag published an article in one of the Social Security Administration publications, and Peter said that healthcare would be 20% of the gross domestic product in 2015. And you can see the numbers in front of you. I don't have time to elaborate, but I'm here all day, and so if you should care about that trivia, I'll be happy to go over it with you. But Orszag said healthcare would be 20% of GDP, and then Obama said, well, we can't let it go beyond that. We have to stop the cost curve. That was managing the cost curve to prevent it from going up anymore, and the Democrats fumbled around a bit, came up with the Affordable Care Act to keep healthcare at 20% of GDP. Well, what is healthcare in percent of GDP? It's 17% as the country as a whole, so if it's 18% in Virginia, you have either a little margin to play with or a little more to cut. I'm not sure which. But the marketplace as a whole, for reasons I will elaborate in just a moment, has decided healthcare is not going to 20% of gross domestic product. And what blows my mind, even though it's 3 whole percentage points less today than it was about 2 months ago, the government came out and predicted that it would be 22% of GDP by 2025. And I don't know what they're smoking, quite frankly. But they are in the district, right? So I guess we do know. But useful predictions. And I'm not slamming predictions, for crying out loud. I've got 2 books about how to do them, and I was well trained in them. And you can make a good prediction about where healthcare will be if how things worked in the past is going to continue the same way in the future. But the U.S. economy, which Barry has already referenced and is your day in, day out concern, and the healthcare sector within it are not going to continue operating the same way in the future. So this whole premise of Peter Orszag's prediction, or any other prediction about healthcare, that might be money we're going to spend, or personnel that we're going to need, or drugs that are going to be short, it isn't going to work, because I would argue there are 4 dramatic shifts that explain how things worked in the past. I'll go through these quickly, and again, be here all day. But actually, you don't really need to see. Now, just talk about this. I'm so impressed with the people that are going to be following me, because you're going to get much chapter and verse from them on all of these changes. And several of the people out in the lobby there, too, are doing these things. But we're seeing a revolution in biological science. In fact, I had the delight of having dinner last night with 5 other people who were involved in this conference. And we spent a good deal of our time talking about the scientific changes. This shift from the one-size-fits-all clinical paradigm, where in the 20th century, which encompasses the almost 20 years that I spent teaching statistics and research at 2 medical schools, meant that you did these large multi-site randomized controlled trials, the gold standard of research, trying to get more and more people so that you could net out all of the possible differences that might explain their response to a new drug or a new surgical intervention, on the assumption that everything that could explain the outcome was spread out over enough people that you were looking at the same disease. And now we know that is not the case, that indeed every single disease has many, many different variations. Last I checked, we were looking at 7 or 8 very different forms of breast cancer, 4 or 5 very different approaches, very different operating systems within the tumors, if you will, for prostate cancer. And just go down the list. Coronary artery disease. I even once, for a consulting gig, showed the genetic differences in patients for macular degeneration. So we now realize how different patients are in this whole concept. And again, it's embedded in the Affordable Care Act of finding the solution that can be applied to everybody is so inconsistent with our understanding of how different we are in diseases. Therefore, we realize, and you don't have to have a PhD in economics to figure this one out, that we're going to have to find the best cost-effective ways to target the therapies, match them, if you will, to individual disease characteristics and epigenetics, which is our fancy professional word for all the other factors, your diet and your behaviors and whether you smoke and whether you drink and drive, or now it's text and drive, I guess. But cost-effective care, and I'll conclude on that point really, means that we shouldn't throw resources at society as a whole. We need to focus them on the people that are most likely to benefit and recognize the differences in their disease. This will dramatically change in a way that the providers in the audience readily understand, and hopefully the business community is aware of it. It's shifting the focus to population health and figuring out the best allocation of resources to make all of your employees as healthy as they can be. And that doesn't mean giving everybody the same resources. Half of your employees don't need any health care in any given year. So why dole out something to everybody when you've got 5 or 10% of your patients that are, or your employees, your beneficiaries in your plan, that are costing you at least 60 to 70% of all your resources. So we're going to manage patients' diseases and the like, and that means patient-centered teams. And the future of healthcare, and I see this in every academic health center where I have the opportunity to make a visit or I talk to friends, is the academic programs are now focusing on not just training physicians in this silo and nurses here, but bringing everybody together in the same teaching, the same understanding, the same communication skills in schools of nursing, pharmacy, what have you. And that's going to become the best practice model, and again, part of what you need to nurture in your relationships. Information and communications technologies really make this possible. I'd be wasting your time to talk about the change in medical science if we couldn't translate that into real changes in day-to-day clinical practice. But we can due to robust information communications technologies. In fact, the machine that's going to change healthcare probably more in the future is right here in my hand. Not necessarily my iPhone, but the smartphones and the tablets and the like, you know, that can tie all this together. In fact, someday it's going to become the next electronic health record. People will get it. And so we need to integrate our electronic records, and as even the leaders of the ARRA, the High Tech Act, have been beginning to reveal just over their speeches in the last month, the way we've been doing it with meaningful use is apparently going in the wrong direction, which I've felt for a long time. But we still need to integrate all the data, and there's a business opportunity for some of you in the audience. Telemedicine, overcoming the barriers of place and time, which is really rampant. And by the way, Virginia would be seen as one of the probably top 10 states easily in the country for doing good things in telemedicine over the last couple of decades. But the mobility of information is going to allow us to no longer think of the hospital as a big brick building with beds where patient care is centered. Increasingly, we're going to find home, work, retail, medical travel destinations. And I'm happy to say the first three of these, home, work, and retail, are all represented by people on the panels that are going to follow me. So I'm not making this up or pandering it to you. But we've got to take the new medical science and use the new technologies to bring it to the people in the spirit of getting the best bang for our buck with the populations we serve, because the economic forces are really changing. And governments and employers, which consistently paid more and more, and the Obama administration assumed in January of 2009 would happily bring healthcare up to 20% of GDP, have put their foot down and said, we're not going to do it anymore. They've leached you as employers and you as Virginians, you know, with your state politics. Clearly said, we're not going to put up with this. We can't keep paying. And we've got to get rid of the idiocy of fee-for-service. If there's one common denominator that I think is pretty much undisputed in any political sphere that addresses health reform, it's that fee-for-service, this quantity-focused thing, has got to yield to focusing on the value of what we get for our money. And I know with your business coalitions and the like, you're doing good things to understand that point. But demand is going to change as the patients get their skin in the game, which is a big part of the Affordable Care Act, which effectively doubled the patient's out-of-pocket requirement. And in fact, the mandate, which was upheld in the last Supreme Court decision, and we're all holding our breath to see what the next one's going to be in about 2 weeks. Thank you, Virginia, by the way. Patients don't have the disposable income to pick up their share. And in fact, one of the 2 reasons that the Affordable Care Act's implementation was delayed from its passage in 2010 until this year, really is the first, well, last year with the full year of the mandate, is they said, well, it'll take 3 or 4 years for the economy to recover. Well, the economy hasn't recovered. Today in 2015, average worker spending power is less than it was in 2000 to this day. So things haven't moved real well. And that's why you see last week the American Hospital Association in its daily news feed featured an article about little difference between being insured and uninsured. The AHA went to the wall with the powers that be in Washington to make sure that the health insurance would be mandatory on the assumption that they would end up with more resources. And now there's study after study, especially Commonwealth, which is quite politically neutral, saying it hasn't worked out that way. that way. And some of you may have seen the article in yesterday's Wall Street Journal reporting a Moody's study of the industry, finding that nonprofit hospitals have not gotten more revenue as a result of the Affordable Care Act. And yet we're all told that this is supposed to be a panacea. Well, that gets to my last change, why we can't really make predictions, is because we had a law that was passed in a very rushed legislative session. And if you want to hear shameful politics, come catch me during the break, because I was vice president of Xerox at the time when all that was happening, responsible for following what was going on in Washington. And it's scandalous, but it was rushed through. The legal challenges, not only King v. Burwell, but the previous case that gave us that mixed decision. There's a long line of other cases to challenge the Affordable Care Act. Neither the administration nor Congress has the money to implement it. In fact, the only federal agency that got more money to implement it was the IRS, and that's a big part of what's at dispute in the case that will be announced in the next couple of weeks. And so the Department of Health and Human Services has responded to all of these challenges by simply waivers, delays, program cancellations, and giving responsibility to health reform to the states. Now, to a lot of Democrats that I know, that's seen as failure. But I would argue you in Virginia are actually on the leading edge of all this, because it means that although there are all these federal regs and the affordable, the accountable care organizations and other things that we could talk about, the point is the federal government is constantly punted to the states. So how great to bring together 500 people from a state that have opportunities to reinvent healthcare. So given all these changes, and hopefully my convincing argument that you cannot predict the future of healthcare, which is why anytime a journalist calls me and says, would you predict? I don't do predictions. So what can I do? Well, I can forecast. And a forecast, unlike a prediction, which is a specific value, is an estimate of the probabilities of possibilities. And I wrote a book about that, so the crystal ball idea, upgrading leadership's crystal ball, is near and dear to me. But I can make it simple. By the way, the reason I did that, I was originally a weatherman. Before, I ended up in healthcare in 1969 when I graduated from college, totally by accident. I was assuming I'd go back to graduate school and write another paper on atmospheric physics or something like that. But I was actually a weatherman. Here's a picture of me in the mid-'60s using a Doppler radar. But I know forecasting. Just like I could teach you how to do prediction, I know a lot about forecasting. And that's really straight out of weather. You collect your weather data, water, temperature, pressure, wind, the things that explain whether it rains or whether there's a tornado or whatever. You collect the variables, and then you look how different combinations of them yielded different outcomes. And so what you end up with is forecasts. And I'll just quickly give you my weather forecast, weather between quotes, for the future of the healthcare climate. Is healthcare going to continue to grow? Well, the government, obviously wrong, said it was. Any economist or any forecaster, any weatherman would never say something couldn't happen. And I'm almost at that 10% fudge factor, but I'll say there's a 15% chance of growth in healthcare, a 45% chance of stagnation, and a 40% chance of decline. So very slim chances that any of you in the audience can assume you can survive simply because there will be more money coming into healthcare. I really think 2015 will go down as the year, maybe even 2014, to go back a little bit, is the year when health spending peaked. And so when you look at the future, it's not this 20% that the government has predicted, but my forecast says few people see an increase, most people see stability, and a slightly smaller number will see decline. And so my forecast for the future of the healthcare industry is that 30% of the people in the business today, 5 years from now, will no longer exist as they exist today. They will have used one of the federal bankruptcy paths, anywhere from complete liquidation through being acquired for pennies on the dollar. So I really see tumultuous times. There are a lot of losers coming in healthcare in the next 5 years. 45% are going, in my forecast, to continue existing, but very precariously. It won't be fun to come to work, but you'll make payroll or you get paid. But 25% are going to thrive by fixing the way healthcare is delivered. And that's what so excites me about the way the panels were put together, because the people that are going to follow me are going to be following the same vision that I had in the last book that I wrote. And what I want you to focus on is the graphics. I believe we need to reform healthcare, and I doubt that any of you in here are happy with what it has been overall, but we've got to find another way. And so my last 3 or 4 minutes are really on that focus. And I've summarized it, but you don't have to go out and buy the book. I'm quite capable of summarizing it, and that'll be in your notes. What I'm going to do for my remaining few minutes is really, instead of looking at the political reforms, which I've already indicated are useless, in fact, negative, counterproductive in my mind, what's the new realm of possibilities, and what can you do collectively, the business community with the provider community, exactly the people that are in this audience. And again, I'm not pandering to you because I've written a lot about this. To become efficient, namely to get the waste out of the system, and to become effective, to deliver a product that's as promised, which was an acceptable promise. And that means getting the waste out. Well, real quickly, is there waste in healthcare? When I wrote the first edition of Paradox and Imperatives with Mark Hagland 6 years ago, 7 years ago now exactly, people said, there's no waste in healthcare. So we referred to a few articles. We had about 20 that we could cite that showed waste. But the American Medical Association has some great economists looking at that. And about a year ago, they published an article, and they looked at over 60 articles in refereed journals studying the business of healthcare and found that the lowest of 60-some articles that looked at waste in healthcare said at least 21 cents of every dollar was wasted, contributed nothing to a patient's health, and in some cases made patients worse. The midpoint was 34 and the high was 47. So I take it as axiomatic that a little better than a third of every dollar we spend on healthcare is wasted. And what I'm dedicated to is trying to keep stability at 17 or 18% of GDP, if you're comfortable with that in the Commonwealth, and then find the ways to reallocate things so you get the healthiest possible population by reallocating the waste, because no more money is coming in. And you'll get the slides, so you'll be able to see the specific detail. But the tactical response, and the one that I see so commonly and have, interestingly enough, increasingly been asked by the American Hospital Association to address in my writings for them, is the horizontal, the larger merger of other health systems, hospitals making larger and larger networks. But I'm not convinced, in fact, I am convinced quite the opposite, that that's not going to work, because I constantly remember what I learned in 9th grade, the first law of parasitism, don't kill the host that feeds you, right? So that's just, we're continuing the battles between the provider community, the purchaser community. So I think the strategic response, reallocating things, is exactly what's in this room. Vertical partnerships of purchasers, payers, practitioners, and the like. And so really what it boils down to is the first corollary of the law of parasitism, that if you're not at the table, you're on the menu. And you're all at the table. I mean, that's what excites me. So just 2 more minutes to finish this off. Healthcare is like an SUV. When I wrote the book, I happen to be preparing, I'm a runner in my other life, and I happen to be preparing for a race through Lincoln Park, where I live in Chicago. And I saw an SUV, and I said, that's it. Healthcare is an SUV. Too big, too expensive to insure, not safe. Anything you can say about healthcare, you can say about an SUV. So I started figuring out, why not find less expensive ways to get where we want? Now, okay, I got a good graphic artist who works for me on occasion, but this is what I really saw, is somebody got it in a very expensive $38 a night parking lot close to where I live at Diversity Harbor. Someone's 2 for 1. So we've got to downsize, we've got to reallocate, find different ways to get where we're going. So my last real content slide is the challenge to you, which is going to be amply illustrated by the rest of the presentations between now and 2 o'clock, is to replace the traditional care models. They're not working. We know that they're not going to get us where we want to be. And to customize things to local marketplaces. Do what's going to work in the Commonwealth of Virginia. Do what's going to work in Roanoke. Do what's going to work in Richmond. Just go down South Boston. Doesn't matter. No more one-size-fits-all. Nurture vitality, just as the great healthcare systems in this country have done. Optimize population health by strategically, in other words, reallocating resources, shifting from acute care to disease management, to going after the patients that are spending most of your money and making them better off. And I think that can only be done with the business community. Constantly improve performance. Do the healthcare right all the time as inexpensively as possible. And the business people in the audience know about that. You wouldn't have survived in your many different businesses if you couldn't do that. So a great opportunity for the providers, many of whom are getting that. Hats off to them. But this is something you can all do together. And then not only constantly improve performance, but develop these new payment and revenue mechanisms. Look for the new kind of relationships. And last night at the dinner conversations, I heard of at least 2 really exciting, quite frankly, nationally significant relationships between insurers and providers that are going on right here in the Commonwealth of Virginia. And that's the wave of the future. And my last point then is to create long-term relationships. I can tell you as an insider, and I'm sure that the healthcare colleagues that are at the table and soon to come up on the stage would agree with me, healthcare doesn't turn on a dime. It takes a couple of years. And one of the reasons we've failed at a lot of things is we only tried it for 2 or 3 years. I am firmly convinced and would expect my colleagues, they're welcome to disagree with me, but it takes 5 years. And so we've got to come up with multi-stakeholder partnerships where we realize we're committed to each other long enough to actually see the results. And so what we're really boiling down to is you taking the reins, doing something that I think is well characterized by Margaret Mead. Never doubt that a small group of people stakeholders, citizens, can change the world. Indeed, it's the only thing that ever has. It's what made Mayo great, Cleveland Clinic great, Geisinger great, but all very different. You can do the same thing, not only to make Virginia different from other states, but within the different Virginia markets. And so my last slide, I leave you with this one. perhaps as a graphic representation for the rest of the conference, is look at the egg and don't figure out what the folks up in Washington can do for you, but rather imagine what you can make fly in Virginia. You do that, and we'll be having more meetings and great successes to celebrate. Thank you very much.